Lymphoma Hub podcasts, brought to you by Scientific Education Support.
Hello and welcome to the Lymphoma Hub podcast. Today we'll be hearing from Gilles Salles of Memorial Sloan Kettering Cancer Center in New York, US.
Hello, it is my privilege to discuss with you the abstract that will be presented during the ASH meeting regarding the trial called SYMPHONY 1. SYMPHONY 1 is a study that evaluates the role of tazemetostat, the first EZH2 inhibitor, an oral agent, which is put in combination with lenalidomide and rituximab. The rationale of this combination is obviously the efficacy of tazemetostat as a single agent in patients with follicular lymphoma, targeting this enzyme, which is key in B-cell biology. And besides the effect on the tumor itself, it looks like this tazemetostat may have an effect on the EZH2 and PRC2 complex, which may reinforce the immune response against tumors. So in this trial, this is a phase 1b result of the study that evaluates the feasibility to combine tazemetostat at different dose level, 400 milligram BID and 800 milligram with R-squared. The results that are shown in this study are really bringing the feasibility of this combination. R-squared was delivered classically as it is developed in the Augment study, and tazemetostat, as I said, was given on a 3+3 dose escalation design at different doses from 400 up to 800 milligram BID on 28-day cycles, so continuously. And patient after that will continue tazemetostat as a maintenance. The inclusion criteria were classical for relapsed follicular lymphoma, and the data we present are reporting about 44 patients, the majority of them having obviously advanced disease, 1/3 of them being refractory to rituximab, 27% of them being PD24. The majority of patients were wild-type for EZH2, and only 16.7% were mutated for EZH2. The feasibility is clearly shown by the exposure of the drug, which is over 90% for tazemetostat, over 90% for lenalidomide, and 100% for rituximab. So this combination is feasible. There were obviously some dose modification with lenalidomide, sometimes with tazemetostat, sometimes with rituximab, but very few real interruptions or discontinuation. The most common side effect was neutropenia because G-CSF was not mandatory and not recommended prophylactically, but those patients had to receive later G-CSF as recommended by conferences. There were treatment emergent adverse effects, including COVID infections, as we may expect. Otherwise, most of the side effects were essentially of grade 1, 2, and those that you will expect in this population, especially treated with R-squared regimen. The overall response rate observed in 41 patients was of 97.6%, and 51.2% of the patients had a complete response. So encouraging result based on this preliminary analysis. Median PFS, median DOR were not reached. And when we look at the population of patients based on their EZH2 mutation status, on their sensitivity to rituximab, or whether or not they were POD24, there were really no difference in the initial shapes of the PFS curve or response rate between these different populations. And for patients that had a complete response, it appears again on these preliminary results that the responses are durable. So encouraging data demonstrating the possibility to combine tazemetostat with R-squared, and this is the foundation for the common phase 3 data of SYMPHONY, which randomized patients between R-squared as a standard of care or R-squared plus tazemetostat, relapsed follicular lymphoma, and I encourage you to participate to this study, which try to answer an important question: how can we leverage the result of R-squared and then treat patients with this combination of immunotherapy and an epigenetic modulator? Thank you for your attention.
Thank you for listening to the Lymphoma Hub podcast. We would also like to thank our supporters: Bristol Myers Squibb, Genentech, Insight, Pharmacyclics, Roche, Novartis, AstraZeneca, and BeiGene.
Lymphoma Hub podcasts, brought to you by Scientific Education Support.